Yeah, okay. So, hi everyone. We're going to do some. Anush, are you recording?
I have just started.
Okay, fab. So, we're just going to do some cases today. And it's mainly mod A heavy, but hopefully, like, there's bits of every module in it that you can learn from. Okay, so let's just kick things off. Your first patient is Mr. R. Swanson. He's a 67-year-old male. He's come to ED and he has some difficulty breathing for an hour. So can people start putting in the chat potential differential diagnosis for difficulty breathing?
Oh, I love that COVID-19 is the first thing on this list.
Yep, asthma. Yep. Anything else? An hour of shortness of breath. COPD, yep. PE, yep. So PE and asthma probably wouldn't last for a whole hour, but yes. Pneumothorax, yes. All good stuff. Other things to think about, a pleural effusion, that takes a little bit longer. Pulmonary edema, if they've got an allergy, yep. Exhibit A. Okay, so his daughter reports that he's got a long-standing cough. He's been feeling under the weather. He does not have COVID. On arrival, his sats were 85%. His obs are there. They gave him 5 liters and his saturations came up, and now he's more comfortable but slightly confused. So the question, and these are his latest obs when you're seeing him. So the question is, which of the following is the single best management plan? Are we doing a Menti? Oh my gosh, you are the dream. So the Menti for the questions is there in the chat.
Have a go. It doesn't matter if you don't know the answer.
Anush, tell me when I should.
I'll read out what people answer when they answer.
Thanks.
Are these the correct slides or are these the old version? Sorry, I've just clocked.
Have you, which ones did you put up?
The latest ones you sent me, I think.
Then they're the wrong one. Well, as in these are the wrong ones. Let me just, I've just clocked as well. I'll put the right ones up. Can you?
Sorry. I just realized that none of these answers are correct.
Yeah, I was gonna say, okay, how do I do it? You just upload.
You just click share and then browse. Sorry about that.
Mm-hmm.
Let me know if you can't figure it out.
That's fine. I'm just.
While we're doing that, so like, what are we most worried about in this funnily named patient? Well, I hope you guys get the reference. If you don't, Google it. I guess. What is the thing we're trying to get at here? You can just post this in the chat, or you can talk.
Oh, this is really annoying. I think I've just.
Yes, Parks and Rec. Yeah, it wrecked. Okay, so so it could be a pneumonia, definitely. what else is going on aside from the pneumonia? Yeah, so the important takeaway is this patient septic? And if we go through the answers.
Yeah.
So the reason we had we have a different set of slides was because me and Preena had a bit of a debate about this when we were preparing a couple of days ago. So I think on this set of slides, the correct answer is
the VBG.
Yeah, so on this set of slides, the correct answer is a VBG, but I think our debate was, in real life, you would actually do an ABG because this patient has a respiratory complaint, and that's so. Does someone want to rattle off the sepsis 6? I know that, spoilers, it was just on a slide, but this is something that they can definitely ask you in your OSCE, and I'd be quite surprised if it didn't come up in your OSCE actually, because it's a big thing in the curriculum. 3 out, yeah, urine output, cultures, and lactate, and then what's in? O2 fluids and antibiotics. Yeah, and the only thing before Preena continues that I just wanted to make clear is there's always a bit of confusion about when you do an ABG or a VBG, because ABGs are very unpleasant for patients, and we generally try and avoid doing them unless they're absolutely necessary. But if anyone has a respiratory presentation, so this patient is desaturating on room air, they've got a high resp rate, that means you need an ABG, like a VBG won't suffice. If you're getting a lactate because you're worried about something else, like mesenteric ischemia or like some other kind of ischemia, then a VBG will suffice. But if you're worried about a respiratory complaint, then you need an ABG. So we did change the slides. I just uploaded the wrong ones because I'm stupid.
Yeah. Okay. So we've talked about sepsis, but I'll just reiterate. So in an OSCE setting, it'd be like, I'd use an A2E approach, do the sepsis 6, and just try and get into the habit of being able to rattle them out. If you're ever worried when you're looking at a respiratory question, like, is this pneumonia? Do I need to use like the CURB 65? Do I need to use Q-SOFA? My general advice would be Q-SOFA trumps everything else. Sepsis is the thing you want to rule out before the other respiratory complaints. So if they fit Q-SOFA, run with that. If they don't fit Q-SOFA, then see if they fit a CURB criteria, and that's what the answers and the options are going for. So if we look at the answers, and we've talked about the ABG, VBG component, does anyone know why, when you're taking blood cultures, you do the aerobic bottle first? Okay, so this is what your butterfly needle looks like. Exactly, perfect. So when you get your butterfly needle out the package, you've got the needle, this bit of tubing, and then the blood culture bottles go into this vacutainer here. And when you put that first bottle in, all of the air in between the bevel of the needle and the top of the bottle that you've inserted, all of this bit here, that's going to go into the first bottle. So you want that to be the aerobic one, and then the anaerobic one you do afterwards. And in terms of the antibiotics, this person's quite clearly septic. You would just give them IV antibiotics. And even if you'd taken the CURB 65 route with this question, with their OBS, you would still end up using an IV antibiotic. Okay, so the next case, moving on, is Leslie. She's 14-year-old, and her parents bring her in due to excessive vomiting. She's recently been to her GP, who suspects a UTI due to dehydration, and she started a course of trimethoprim yesterday. So can I get in the chat just rattle off some differentials for vomiting? Don't look at her. Don't worry about the VBG right now. Just tell me things that could cause vomiting.
I'll cry if someone says COVID-19. Because you're not wrong.
Gastroenteritis, food poisoning, yep. E. coli, yep. DKA, yep. Alcohol, yep. Pregnancy, yes. And she might be 14, but you've always got to rule it out. Okay. Drug induced, yep. Okay, so they tell you that she's got 3 months of lethargy, tiredness, and weight loss. And this is her VBG. So I'm going to give you a few minutes to look at it, and I want you to answer this question, which is, what's the best description for the disease process that's happening to her? So there's kind of 2 steps to this: work out what's wrong with her, and then try and see if you know the disease process behind it.
This is a question that comes up a lot in exams, just generally, and in real life, if you go to A&E, so it's quite useful.
Anush, can you tell me when there's enough answers on the Menti?
Yeah, we'll do. Yeah, so 1 person's answered so far. So it's the same code as before. It should work, sorry. Tell me if it's not working. So we'll give you another 10 seconds to answer. Voting is closed. So the majority went for the last one. 1 person went for the first one.
Okay. So which of your differentials for vomiting has she got, or what's her most likely diagnosis? You've all got it right, so someone just needs to put it in the chat. If you have an insulin deficiency, what's the condition? Yeah, DKA, exactly. So she has got the right answer was a metabolic acidosis due to insulin deficiency. So she's 14 years old, so it's likely type 1 diabetes, and she's in DKA. So with DKA, this diagram, just once you get this in your head, you can work everything else out. So if you've got DKA, you've got type 1 diabetes most of the time. Sometimes people do have type 2 diabetes and they present in DKA, but most of the time, especially if it's a young patient, they've got type 1 diabetes. And that's when they've got a lack of insulin, they're not making any. And 2 things happen because of that. You get hyperglycemia, like nothing moves the sugar out of your blood into your cells and muscles. And because you haven't got any insulin, your body just thinks it's starving. So you've got a continuous fasting state as well. And because of the fasting state, you start producing ketones, your body thinks it needs to use other sources to get more sugar, and that just rampens up your hyperglycemia even more. And because sugar is osmotically active, you get in your kidneys an osmotic diuresis. So you get excess sugar filtered out, water follows it, and you just end up weeing it all out. Hint, hint, the UTI in her history. And you end up getting really severely dehydrated. That causes renal hypoperfusion, like pre-renal AKI sometimes, but most often it's a metabolic acidosis. So the way you break this cycle is you treat the dehydration with some fluids, and you treat the lack of insulin with exogenous insulin, basically. And if you don't give one or the other, you're not going to break the cycle. If you just give them insulin and no fluids, you'll like deal with this bit up here, but she will still be severely dehydrated. More than oral intake can like solve quick enough. And same with the fluids. If all you're doing is rehydrating her but not actually tackling the insulin, you're going to get the same problem happening over and over again. So on a VBG, now that I've kind of explained this whole process, how does it look? Can anyone put some of the features they remember from the VBG in the chat for someone who has DKA? What would you expect to see? Low pH, yep. So they'd be acidotic, yep. Low bicarb, yep. Maybe a metabolic acidosis, good. What about their electrolytes? High anion gap metabolic acidosis. I like the sound of that, yes. We'll come to that in a few slides' time.
What would happen to their potassium? That's the important one for you. The clue is think about your hyperkalemia management. Yeah.
Exactly. Cool. Okay, so you suspect that she's likely to be suffering from DKA. Yes, yeah, a high rest rate, low CO2. Good, Jordan. Which of the following defines / is diagnostic of DKA?
Have a go at that as well. Yeah, it's on Menti again. After this one, should we just go back and go through some of the other options on the previous one?
Yes, yeah, we will.
You can't assess CO2 in a VB. Okay, so you can assess it to an extent, you just cannot accurately assess CO2. Because if CO2 is low on a VBG, then it'll definitely be low on an ABG. But like if it's normal, then you can't really tell. But yeah, you're absolutely right, Soma. You would ideally need an ABG. I'm gonna give you guys 30 seconds to come up with an answer. Sorry, I've just discovered that you can do this 30-second countdown thing on Menti, so I'm just really excited by it. Okay, so most people went for A and then a couple went for E.
Okay. Good. So the answer was A. So in DKA, it's quite easy to remember because they're diabetic, so they're going to have a high blood glucose. It's not the fourth option. K is like keto, so they'll have a ketonemia or ketonuria, and A, acidosis, and they'll have a raised anion gap acidosis. So we'll talk about the raised anion gap in a second, but these three are the defining features of DKA. So they've got to have known diabetes, or their BMs have to be more than 11. So I can see why some of you went for the 10.5. The ketonemia has to be severe, so it's got to be greater than 3, or they've got to have more than 2+ on a dipstick, and they've got to have a acidosis on their VBG. In DKA, sometimes a VBG looks really similar to dehydration, like all their electrolytes are like slightly raised, they've got high sugar, they've got high potassium, they're acidotic, and like if you're acidotic due to like lactic acid or something, you can also be dehydrated. So sometimes it's really confusing, or I definitely found it in 4th year, but the key thing that gives it away in DK is that their sodium will actually be low. They get what's called a pseudo-hyponatremia. And I'll come on to that into the next slide, but now is actually a good time to just go back and talk about this question. Sorry. So in DKA, it's not the lactic acid that's driving the metabolic acidosis. We spoke about how it's the insulin and the dehydration. They can get an AKI secondary to dehydration, but her presentation isn't an AKI. Her presentation in the disease that's occurring is DKA. If you had excessive vomiting, it would cause a metabolic alkalosis, not an acidosis. And now that we've spoken about what happens to your electrolytes, you'll know it's a pseudo-hyponatremia. That might just be a typo.
Yeah, Preena wasn't paying attention when she wrote the question.
So, sorry, I was saying, yeah, so you know it's a pseudo-hyponatremia, not a real one. And the right answer is, obviously, it's the metabolic acidosis that's driven by the insulin deficiency. Okay,
I think it's also worth mentioning in real life and for exams, if you see a low pH with ketones, that's DKA until proven otherwise.
Mm-hmm.
Like that's the way it's managed in like an A&E setting. So that's the first thing for you to check on any kind of gas.
So talking more about the metabolic acidosis, I don't know if you guys have been taught about the anion gap, but basically in a normal person, you have like electroneutrality. So you have all of your positive ions even out all of your negative ones. But when you actually go to measure that, it doesn't come across that way. If you add up the numbers, like your sodium and your potassium on a VBG plus your take away your like bicarbonate chloride, it's never zero. There's always a gap. And that's because a lot of the negative stuff also comes from sort of proteins, albumin, things that aren't necessarily measured. So they contribute to your anion gap. And some causes of acidosis can increase your anion gap, and other causes can leave it the same. And rarely, I've never like even had to learn it, but you can have causes that lower your anion gap as well. But I'd say mainly focus on your increase and normal because they help you work out what's happening in the question. So when you have a raised anion gap, what's happening is you've got some like exogenous acid being produced, be it ketones, lactic acid, and in order to like keep life electroneutral, your bicarbonate is like pairing up with that acid, and all your bicarb gets lost, so your anion gap effectively increases. Does that make sense?
If it doesn't, let us know, because this is like a big thing for exams that they really like.
I'm going to go
okay.
with
yeah.
Yes.
Just let us know if you don't. We can go over again.
And this acronym on the left is the one that I learned for like all of the external acid causes of a like raised anion gap. So lactic acidosis, DKA. If you have uremia, why is it important? Because on a VBG, you can like physically calculate it yourself. So you can just do your sodium and potassium, add them, and then add your bicarbonate chloride and take them away. And normally it should be like 8 to 12. If you've got a VBG in the question and it's like 22, you know that something, like one of the answers is a raised anion gap answer. So it helps you narrow down what's caused it, basically. Because sometimes it's not as clear as the case that we did today. And yeah, I would just learn this acronym. If you have uremia in your blood, that manifests as uric acid, and that's why it causes a raised anion gap.
If I was to point out the most important ones, I would say DKA, uremia, lactic acidosis, and salicylates are the ones that are really, really important to learn. But yeah, the acronym is very useful in general.
And the general rule is if it's not if it's a normal anion gap acidosis, it's anything other than this, basically.
This is
again,
definitely the shorter list to learn. So learn this list.
Yeah. So again, if it was normal in the question, you could just use this to rule out some of the answers as well. Okay, so continuing on with Leslie, she has DKA. Which of the following is the single best description for her management?
You have 1 minute for this one. Oh, I do like it when the answers are split.
Is there a split?
There is.
Oh.
It's almost perfectly split.
Oh no.
Right, last second. Okay, so most people went for A.
Okay.
Almost as many people went for E, and a few people went for C.
Okay. That instills confidence. So the answer was A, but I can see why people went for E. So the key points for DKA management, like I said, you need to break that cycle. So you need to give them insulin, and you need to rehydrate them with fluids. So if we talk about the insulin first, it's always given at a fixed rate, which is 0.1 units per kilogram per hour. I personally learned that last year, and I would recommend that to you guys as well. In terms of the fluids, this is the fluid regimen you use. So you give them 1 bag of sodium chloride over an hour, and then 1 bag, and then all the other bags have potassium in it. And you give them a litre over 2 hours, another one over 2, 4, 4, and 6. Again, I'd learned that. But the important thing, I guess, practically, and also practically, I guess the important thing is you do a VBG and a fluid assessment after every bag. So in a fluid assessment, what are you looking for in the patient? Give me, just comment on the things that you would look for in a fluid examination.
This is one of the they never teach you properly, but it's like the most important thing in the hospital.
Yeah.
Oh, you guys know it. Yeah, really good.
Interga, cap refill, JVP, good. Yep. Anything else? Edema, wear, mucous membranes, yep. Lung bases, their blood pressure, good. Legs, yep. Also sacrum and in their lungs, check for bibasal crackles. So yeah, I think you guys have got mostly everything. I'm just checking if you missed anything. No, okay, fine. If you're looking at them and they're like slightly distended, you can always check for ascites as well. But that's most of the fluid examination. So you aim for their potassium to be between 4 and 5 after each VBG. And like we said earlier, insulin causes your potassium to move into your cells. So they're at risk of hypokalemia, and that's why you add potassium to each bag. The way I remembered that you'd never give it with the first bag is because if you were to give someone 40 millimoles of potassium in an hour, that would be really harmful. That'd be like something they do in ITU. So you never give someone potassium that quickly. If you think about like your maintenance fluid prescribing, the limit is 10 millimoles an hour. So that's like 4 times safe rate. So I always remember that you start it on the second bag. And if the potassium is actually quite high. If it's more than 5.5, you don't need to replace it. If it's really low, you need to get someone senior involved and escalate. So the other thing about DKA management that you need to remember is if you're giving them a fixed rate insulin and they're not eating, they're vomiting, eventually at some point they're going to become hypoglycemic. So when their sugars drop below 15, you start them on dextrose as well. So you give them a sweet bag and a salt bag, and that's just how I've remembered it. And Leslie, for her, this was her first presentation. But if the patient has known type 1 diabetes, you make sure that you continue their long-acting insulin throughout. So don't change their long-acting regimen. Don't stop it. Stop their short boluses after meals, but keep the long-acting. And can you guys name some like triggers? If you have type 1 diabetes, what can trigger you to go into DKA? Infection, yep. Acidosis, yep. Missed insulin, good. Yep, I feel like everyone's got the drug compliance bit down. Stress, yep, but what kind of stress? Trauma, mental, sure, yep. Physical stress as well, yep. I'm not sure about amivirin.
I mean, technically any acute illness can precipitate DKA, so you could have said anything in reality. Yeah. But yeah, the common ones are infection, missed doses, and yeah, stress is like actually a big thing because that's why there's like special rules for like people with type 1 diabetes when they sit exams because exams cause such a spike in your cortisol that can precipitate a DKA thing. So far your answer is very correct, unfortunately.
Also, if the first thing that comes to your head is missing insulin, remember the counterpart, which is missing food as well. So if they're vomiting, then not keeping their oral intake in as well. Sometimes that can trigger DKA. Okay, so I think this is where I'm going to hand over to Anush. I think.
Yep, cool.
Yeah.
Before we go on to this, there is one thing that's worth talking about insulin. So say you've initiated a fixed rate insulin infusion to treat someone on DKA and they're getting better and they're now like maintaining oral intake, you think they can have like an entire meal and there's no issue with it. Do you know how you would switch them back to their subcut insulin? Does anyone know? It's a bit weird. So would you keep the fixed rate going while you start the subcut, or what would you do? There's a very specific thing you do, unfortunately, before we go on to type 2 drugs. Oh, exactly. Yeah. So once you're confident they can keep down an entire meal, with that entire meal, you give them their subcut insulin, and then you wait an hour, and then you stop the fixed rate insulin. Do you know why you need to wait an hour on the fixed rate insulin, Patrick? This is a more important thing for like post-surgical things. Yeah, it's the half-life. So the half-life of IV insulin is really short. So it'll run out in like 30 seconds to a minute. So if you stop that, they're gonna go back into DKA. So you need to wait an hour. Yeah, really good. Fine. So we're going to talk about some drugs used for type 2 diabetes. So remember, people with type 2 diabetes are less likely to go into DKA. They're more likely to go into HHS. But it's just something that people asked for. So we're going to go through it. So what is type 2 diabetes? Can someone give me a definition? like a one-line summary of what type 2 diabetes is? It doesn't have to be perfect. If you were explaining it to like a layperson, what would you say? Actually, no, you're explaining it to like a second-year medical student or a first-year medical student. Absolutely. So it's a state where there's decreased sensitivity to insulin, or there is a relative lack of insulin production, often due to B cell dysfunction. Yeah, exactly. And as a result of that, you get high blood glucose. And you get like a similar presentation to type 1 diabetes, polydipsia, polyuria, tiredness, fatigue. It's a similar presentation. The main difference is people with type 1 diabetes may present with weight loss, especially like teenagers. Type 2 diabetes tends to occur in people with higher body habitus. That's like the main distinguishing thing. So based on this definition, what kind of things can we target with drugs? So you know that it's either due to a lack of sensitivity to insulin, or you know it's due to a lack of insulin, and you know that there's a really high blood glucose. So what kind of therapeutic targets, if you were thinking about it scientifically, could you go for? So you can try and force the body to increase how much insulin it's releasing from the beta cells. Yeah, that's one group of drugs. What else? You can try and increase how sensitive the body is to insulin. Yeah. And then like the third one is a bit of a sellout category that I made up, but it's like finding other ways to get rid of glucose from your body. So you can, we spoke about these. You either increase the sensitivity, increase insulin, or reduce glucose by other means. So can anyone give me some drugs that increase the sensitivity to insulin? So what is the first drug that we use on every patient who needs drug therapy? Yeah, metformin, which is a biguanide. Okay, any other drugs that increase our sensitivity to insulin? There's one other group of drugs. You can give me a name, or you can give me the group name. They're both on here. Correct. Pioglitazone, which is one of these PPAR gamma agonist things. Yeah, so those are the two drugs that increase your sensitivity to insulin. Incretins, we'll get to it in a minute. So what is like the big category of drug that increases insulin in your body? Aside from just giving you insulin. That is also an option. Yeah, so sulfonylureas, so exogenous insulin, sulfonylureas force your pancreas to produce more, and then some less commonly used drugs, but you'll still see them around, are exenatide, which are GLP-1 agonists, and sitagliptin, which is a DPP-4 inhibitor. So this is where incretins come into it. So incretin is like a chemical that augments the release of insulin from beta cells. Incretin is basically GLP-1, so they're basic. It's a GLP-1 agonist or incretin mimetics. DPP-4 is an enzyme that breaks down incretins, so inhibiting DPP-4 means you have more incretin, so you have more augmentation of insulin release. Okay, and then can anyone think of a drug that can reduce your blood sugar by neither of these means? There's one drug you need to know. Yeah, SGLT2 inhibitors, and what do they do? How do they work? Yeah, so effectively you pee out glucose. So we'll go through each of these again. So the two drugs increasing insulin sensitivity. Metformin, importantly, can cause weight loss, and there's this risk of lactic acidosis. So if someone has an MI, you want to stop their metformin. If someone has an AKI, you want to stop their metformin. Oh, someone took control of my slides. I've taken control back. Fine. So that's basically like the important stuff for metformin. You usually take it, you can take it between 1 and 3 times a day. Is that going to come up? I don't know. Probably not. So pioglitazone is quite an old drug, has quite a few side effects. Can anyone think of any contraindications to giving pioglitazone? They do like asking about contraindications for this one. So PPAR gamma is basically a molecule that improves sensitization to insulin. Again, yeah, so it can cause fluid retention, so it's contraindicated in heart failure. And then there's one other really, really strange contraindication. It's some kind of cancer. You might not have heard of it. It's super rogue. So it increases your risk of bladder cancer. Yeah, exactly. So if you've had previous bladder cancer, you can't have this drug. Remember those two? They're kind of strange. That's all they'll ask you about pioglitazone. But do not give people with congestive cardiac failure pioglitazone in an exam. If they're like, this person has a past medical history, avoid at all costs. Fine. The drugs acting by increasing insulin are sulfonylureas and then the 2 incretin related drugs. So can someone remind me the mechanism by which sulfonylureas cause increased insulin release? This was something that you probably did in second year. I'd be very impressed if you remembered. It's one of those few useful biochemistry things. Yeah, so they bind to the KATP channels. And effectively, if you change the change in the potassium gradient is what causes insulin to be expelled from the beta cells. So that's exactly how it works. If you're producing more insulin, we already spoke about the other two. If you're producing more insulin, what are these patients at risk of? Hypoglycemias, absolutely. So if you understand how it works, you can kind of figure out its side effect profile. The only other thing of note on this slide is exenatide is a very expensive drug. This group is very expensive, so you can only give it to people who are unresponsive to other diabetic treatments and have a BMI of over 35. We'll go through the treatment ladder in a minute. So these drugs all kind of share the same side effects. The main one to know about is hypoglycemias, which is highest with sulfonylureas because they increase the amount of insulin you're producing by the most. Again, they also all increase your risk of pancreatitis because they're forcing your pancreas they're basically stimulating your pancreas to produce more and more insulin. And when you're stretching your pancreas to the limit, there's a risk that it's going to start undergoing autodigestion, which is the basic principle behind pancreatitis. And if you have, what else happens if you have more insulin going around your body? What happens so the opposite of what happens in type 1 diabetes? Yeah, so they gain weight. So except for GLP-1, which is very good for weight loss. The other two cause weight gain. This is more year 5, but you'll learn this next year. But like a big problem in managing type 1 diabetes in children and teenagers is sometimes they don't take their insulin because like it causes them to gain weight and like they're mocked by people and it's really awful for them. But like it's really important that they do take their insulin because otherwise they're going to go into DKA, and it's not an uncommon presentation. Okay. We spoke about hypos and weight gain with sulfonylureas, but like they also cause they can cause like a peripheral neuropathy, or they can cause SIADH. So what is SIADH? If you had to give me like a 1-line summary. If you don't know, it doesn't matter. So you have too much ADH secretion. Yeah. What is which which effectively leads to fluid retention, and they get well, it's not so much, it's like retention, but it's like they're like euvolemic. So if you did a fluid status exam, they wouldn't show retention. They would show like a normal like amount of volume. The problem is they've got a low sodium. So effectively, they're peeing out too much sodium. You're thinking of diabetes insipidus. But yeah, have a read about SIADH. We'll go over it at some other point because it is quite an important condition and it comes up in comes up in all three modules. We'll go through the actual pathophysiology, but does anyone know how you would diagnose it? So you get hyponatremia on blood tests, but do you know how you would confirm that it's SIADH? Again, we'll go over it another time, but like just quizzing you as we go along. So if you've got a low sodium in your blood, yeah, you do. You take a urine sample. So if you've got a low sodium in your blood, in an ideal situation, you should be peeing out less sodium in order to compensate it. But in this case, you've got a low sodium in your blood. You'll still get a high urine concentration of sodium or a high urine osmolality because you're failing to compensate for it. We'll go through the pathophysiology another day. It's a bit time consuming. Fine. SGLT2 inhibitors. What are the two main like risks with SGLT2 inhibitors? If you're peeing out urine, what could happen? UTI, that's the biggest one. We already talked about SGLT2 channels. But UTI is the really big thing, and it can cause like recurrent thrush. And yeah, so there's this thing called euglycemic ketoacidosis, where because you're peeing out loads of urine, your body starts to think you've gone into a starvation state, even though you're not in a starvation state. It's super wacky. They don't really understand the mechanism why. I asked an endo-reg about this a couple of weeks ago, and he's like, we don't really know why it happens. All we know is it does happen. But yeah, if you're interested, have a read about it. Will it come up? Probably not, but it is interesting. Important things are you'll lose weight because you're peeing out glucose, but yeah, don't give this to elderly people. Again, it's just really unpleasant, and getting UTIs in the elderly is really dangerous because it can lead to them having falls. It leads to them being dehydrated. It can lead them to become delirious. So do not give this to elderly people. So patient gets diagnosed with type 2 diabetes. What is the first thing you're going to do? How are you initially going to manage it? Yeah, so conservative management and lifestyle changes is absolutely the first step. Definitely, yep. Exactly. So what you could work out the severity. If it's like really, really, really high, like if they've got so what's like the best test you can do to look at their glycemic control over the last 3 months? Yeah, HbA1c. If that's like 140, then yeah, lifestyle advice probably isn't going to cut it. But otherwise, you always start with lifestyle changes. Okay, so lifestyle changes haven't worked. What's the first drug that you always go with? Every patient will get this drug. Metformin. Absolutely. And that's like the important bit of management. Like if you know that, you're doing well. Because after that, it kind of becomes like you kind of just make it up as you go along. So if their HbA1c after metformin is still above 58, that means it's not adequately controlled, which means you can add another drug. Doesn't matter which drug, just add another drug. The only drug you can't add is GLP-1 because, as we said, you need really specific criteria for that because it's too expensive. After that, if their HbA1c is still above 58, you add another drug until you're on triple therapy. How often often, how much longer after the first HbA1c will you check again? After you've made an intervention, how long would you wait before checking their HbA1c? So it's usually around 3 to 6 months later, because remember, you can't do it monthly because of the half-life of red blood cells in the body. So how long do red blood cells usually last in our bloodstream? Yeah, so around 3 months. So if you do it at a less than 3 month interval, you won't get like a great you'll still be waiting. You'll still have a period that you're measuring where the intervention wasn't made. So you'll usually wait around 3 to 4 months. Yeah, it's around 90 to 120 days. I think it's 120 days in textbooks nowadays. Great. So fine. If triple therapy hasn't worked and they have a BMI above 35, then you can use those really expensive drugs. If that isn't working, then you need to get them onto some insulin, because like it's really poorly controlled, or they've got very little beta cell function. Fine. So we spoke about HbA1c being the best test for monitoring like long-term glycemic control. We spoke about how often how long you have to wait before doing HbA1cs. So HbA1c can be unreliable in certain disease states because it can be lengthened. I mean, it can be falsely elevated or falsely decreased, and that's proportional to how long the red blood cells are staying in your circulation. So if your red blood cells are staying in circulation for longer than 120 days, then your HbA1c will be falsely elevated. Can anyone think of any states which would cause that? So what states could cause your blood cells to last longer than 120 days? This is a little bit of mod C, but is very relevant to diabetes. So hypersplenism or splenectomy. So if your spleen isn't working properly, then your red blood cells are going to stay alive for longer. So you'll get a falsely elevated HbA1c because there's longer for your hemoglobin to like react with the glucose. So the opposite is also true. So if you have conditions that cause your red blood cells to be taken out quickly, so they last much shorter than 120 days, that can mean that you have a falsely low HbA1c. Can you think of any conditions that would cause a low HbA1c? Any conditions that would cause your red blood cells to be eaten up quickly? So sickle cell and hemolytic anemias are like the main things. So anything that can cause hemolysis can cause a falsely low HbA1c. Good. Fine.
Just
so
to add, sorry, in conjunction with that, anyone who gets a transfusion, you can't use their HbA1c either for 3 months.
Of course, that's really important. Completely forgot about that. I'm sure you guys can figure out why that is.
You won't know which way it goes. It just depends on the donor's HbA1c, so it doesn't necessarily like always elevate or decrease it.
Yeah. This is literally lifted from PassVed because this is the best diagram you will find of this. The right-hand side, I don't know whether it's worth learning. It's up to you. But yeah, I like the simplified version that I made a bit better than this, if I'm honest. So there's a few cutoffs we need to know for HbA1c. So if it's above 48, that's your threshold to start medical management usually. So if you've tried lifestyle and it's still above 48, you need to start medical management. At what stage do you decide to add in an extra drug? It was on 2 slides ago, but let's see how well you remember. So what HbA1c threshold would you choose to start an extra agent or switch to triple therapy if you're on 2 agents? So 58. We'll talk about 53 in a minute, Soma, because that's important as well. So if they're above 58, it's really poor control, and you really need to start another medication. So 53 is an important target. If your patient is not on any hypoglycemia inducing medications, so if they're only on metformin, they're not on a sulfonylurea, Their HbA1c target is 48 millimoles per liter. If they're on a hypoglycemic agent, which is almost always glycoside because it's a very potent drug and it works very well, then your target is 53 because you don't want them having hypos. So those are the important targets. And that's everything we were going to talk about today. Does anyone have any questions at all? Let me just find the feedback form. You can absolutely see the last slide. I'll upload the slides after in a bit as well, so you can just look through them. If you have any questions, I'll stick around for 5 minutes or so. The one thing I'm going to emphasize is this slide. If you can remember that you can group the drugs you use to treat type 2 diabetes into these 3 groups, you're much more likely to remember the various drugs rather than learning them as one massive list. So if you're ever stuck, and this applies to any disease, try and think about like the scientific principles of where can you actually target treatment. This works very well for Parkinson's disease as well, like because you know that there's a shortage of dopamine, so you can increase the dopamine, just give them dopamine or stop dopamine from being broken down. So you can break up a lot of disease processes like this, which will help you remember like the multitude of drugs.
Also, I'd say like learn the contraindications, like the big contraindications for each of those, because like Anush said, after metformin, you're kind of making it up. So the question will always give you enough contraindications to rule out the wrong answers. Yeah. So like the patient will almost definitely be like overweight and have heart failure. Suddenly you can't give them pioglitazone and any of the ones that cause weight gain.
Yeah. PassMed should like keep you well prepped on that because they love asking about that as well. Any questions at all? We finished exactly on time. Does anyone want to see any other slides? I will upload them. Do we need to know about the types of insulin for type 1 diabetes patients? That's a good question. Let me stop recording because we'll probably do that at some point, but like I'll tell you now as well.